All right, how do I get this going here? Give me 1 second. There we go. All right, so thanks, Doug, and I appreciate you inviting me to speak here on vasectomy and prostate cancer. I kind of didn't love the topic because it's been going on for 28 years. So I renamed it, Is There a Relationship Between Vasectomy and Prostate Cancer? Are we still discussing this 28 years later? Okay. And I'm a professor at Yale. I'm director of men's health, but both myself and Michelle Lebrecht were on the vasectomy guidelines committee from the American Urological Society dating back to 2012. So what I'd like to do today is, and this is a list of my disclosures, none of which have anything to do with vasectomy or things like that, except FELA, which is a mail order sperm test that I won't be involved with discussions with today. So these are the topics that I wanted to cover, a little bit about the history of where this relationship came from. Is there a cause and effect relationship between vasectomy and prostate cancer? What, can you hear me okay?
Yes.
Okay. What could be the mechanism of action of a vasectomy causing prostate cancer? And finally, what is the most recent data regarding whether there is a relationship between having a vasectomy and the development of prostate cancer? I'll make a couple of disclaimers here. One, I'm not a statistician, I'm a urologist. It's probably my least favorite thing to talk about, statistics, but there are other people online that probably are better at statistics than I am. Number two, there's a difference between something being statistically significant and clinically significant, meaning statistics mean one thing, but when you have a large group of patients, something that's statistically significant may not be clinically significant. And lastly, the definition of insanity, which is doing the same thing over and over again, expecting a different result. That's what Einstein said. And I think that I'll try to show you that that's the case with respect to this. So this was the paper that got everyone worked up. It was published in February of 1993, the same time the World Trade Center had its first bombing. The Dallas Cowboys won the Super Bowl. So if those of you in this country realize they haven't won a Super Bowl since. And here are the world leaders: Bill Clinton, John Major, Mulroney in Canada, Mitterrand, Helmut Kohl, and others around the world. I'm sorry if I didn't include your country, but I just want to give you a sense of the history of how long back this was. And I was a fellow at Baylor doing a male reproductive fellowship, and there was a big thing coming out. We thought this was going to be the headlines for CNN News, and one of these things happened that day. I don't remember what it was, but something big happened that day that this paper came out, and it really didn't kind of make a splash to the general public as the way we thought it might. And it was a retrospective study, and it evaluated healthcare workers. And what they did was they looked at 14,000 husbands of nurses who had a vasectomy, and they compared them to age-matched controls who did not have a vasectomy. What they found was that the odds ratio, or the relative risk, was 1.56. And it was a little higher if you were 20 years out from a vasectomy. And they postulated, well, the mechanism of action could be a decreased prostatic fluid, maybe there's immune response, anti-sperm antibodies, or suppression of tumor immunosurveillance mechanisms, et cetera. And just to give you a comparison to other relative risks, the relative risk of developing breast cancer with oral contraceptives is thought to be about 1.2. And you can compare that to smoking and lung cancer, which has a relative risk of 9, and a relative risk of not being vaccinated, of dying, compared to being vaccinated from COVID-19, it's 11. So just to give you a sense of like where this came from, it was still, when it first came out, it was a very low risk. And there were concerns with multiple biases, specifically selection bias. Patients that were selected were husbands of healthcare workers, and the group that they compared them to was not necessarily a similar group. They could have been screened differently. They could have had PSA testing differently. And they're much more likely to be screened for prostate cancer. So this set off a series of studies dating back 20 years that subsequently were reviewed by the board of directors of the American Urological Association. They came out with a position statement saying that there was no clear relationship between having a vasectomy and developing prostate cancer. When we sat down to do the AUA guidelines in between 2010 and 2012, myself, Ira Charlotte, and Jay Sandlow, who are pretty active on this group, David Sokol, who also very, very prominent in vasectomy work out of Raleigh, North Carolina, and Arnold Belker, Joel Marmer, one of the fathers, two of the really senior people in male reproduction, and of course, Michel Lebrecq, the Encyclopedia of Vasectomy, sat down and we looked at the data in 2012. And what was found at that point was there were 14 papers on 10 comparative cohort studies, 3 of which showed statistical significance. And the meta-analysis showed 7 cohort studies that showed, again, a very low relative risks of 1.07. 20 case-controlled studies, 4 showed statistical significance, but the meta-analysis of the case-controlled studies, again, showed no statistically significant relationship between vasectomy and prostate cancer. So the panel interpreted this data to suggest that there was no association between age of vasectomy or years since vasectomy with the differential risk of prostate cancer, and that vasectomy does not predispose men to develop advanced or lethal prostate cancer. And this was a statement in the guidelines. Clinicians do not need to routinely discuss prostate cancer and a list of other different things that have come up over the years in pre-vasectomy counseling of patients, because vasectomy is not a risk factor for these conditions. Now, what could be the mechanism of action? I'm just bringing you to a schematic here. On the left, you have the testicle, you have the vas deferens. This is where the vas is cut. The vas then goes through the groin behind the bladder. On the right here, you see the ampulla of the vas joining with the seminal vesicles. And then as the ejaculate comes out, it comes out through the ejaculatory duct, which runs through the prostate. And that's how ejaculation occurs. So some of the mechanisms of actions were thought to be, and these were all kind of conjecture, a decrease in the volume of prostatic secretions resulting in a prolonged exposure to certain carcinogens. Now, we know that after a vasectomy,
Exposición prolongada a ciertos carcinógenos, sabemos que la mayoría del fluido proviene del versículo
carries the vas. An increase in circulating androgens or androgen binding protein, that's not seen after vasectomy as well. The development of anti-sperm antibodies or changes in local immune factors, which may affect immune processes, possible, but again, conjecture. And lastly, increased levels of some molecules in the seminal plasma, such as IGF-1 and IGF-BP3, that are known to involve prostate carcinogenesis. This was really more conjecture than anything else. As I reviewed the literature here, I came up with this paper that was published in the last year or so, and I thought I would share it with the group because it does bring about an interesting concept in how you could explain the relationship here. And this is an animal study. They looked at a transgenic mouse tramp model. A tramp model apparently puts these mice at higher risk of developing prostate cancer. And they broke them into a vasectomy and a non-vasectomy group. And what they found was that there was an increased expression of this tumorigenic factor, ZKScan3, And at 24 weeks, there was tumor expression that was increased in the vasectomized versus the non-vasectomized patients or animals. So he was the first time that I saw potentially a mechanism of action that kind of made some level of sense, even though it hasn't really been developed in the human model or other ones. Now, what's the data, updated data since the AUA guidelines were released? Okay, and I pulled out 3 papers that have been published in the last couple of years. This is the first one. This is a meta-analysis that was published in JAMA, including cohort, case control, and cross-sectional studies. So this is probably some of those studies that were included in the initial meta-analysis. And they looked at their primary endpoint was any prostate cancer. And those of us in urology know that there is animals of prostate cancer that are very low grade, and we kind of treat with active surveillance. And then we have intermediate grade and high grade cancers that are potentially more lethal. And the secondary endpoint was the high grade or the advanced cancers. And there were only 6 studies with low risk of bias. And what they found was the relative risk was 1.03. So basically, 1 is a flip of the coin. High-grade cancer, 1.03, advanced cancer, 1.2, and lethal when you died of prostate cancer, 1.02. So here you're looking at a study that showed really no difference, suggesting vasectomy as a risk factor for prostate cancer. Another study out of Finland, vasectomy and the risk of prostate cancer. This was in the Finnish registry of 38,000 men with vasectomy. Also, relative risk was 1.1, and actually the mortality from prostate cancer was reduced in men who had a vasectomy. The last paper was a published paper from tumor registry from Denmark. And in this one, they looked at the prostate cancer registry, 26,000 patients, vasectomized versus non-vasectomized. And again, this is a study where you saw a statistically significant difference, but the relative risk was 1.15. And again, it comes down to what is statistically significant and what is clinically significant. And I would argue that that's really not clinically significant. It wasn't related to years from vasectomy or frequency of doctor visits. And this was a kind of a commentary made by the original person who had written the paper in 1993, Ed Giovannucci, who's from the Harvard School of Public Health. And what he said was, what is known about vasectomy and prostate cancer among at-risk men is relatively little. And this is 2021. And this is 28 years after his original paper. And I would argue just the opposite. We know a lot about what's going on here. There's really no effect, okay? So I think the summary here, 2021 standards, there's really no new compelling data suggesting a relationship between having a vasectomy and the development of prostate cancer. There's no clear cause and effect. The mechanisms of action are mostly theoretical. And I would kind of bring you back to the comparisons to other relative risks. The relative risk of taking an oral contraceptive and development of breast cancer is 1 to 1.2. That's where this sits. I mean, I don't see anyone stopping taking oral contraceptives because of this risk. And you compare this to lung cancer and smoking, the real risk is 9. The risk of dying if you don't have a vaccine versus being vaccinated from COVID-19 is 11. So I would argue that there's still no need to discuss this with our patients unless they ask, okay? Those are based on the guidelines 2020, 2012, and I think they hold up in 2021. All these papers will be re-summarized in 2022 when the AUA guidelines are updated, but I think we can safely say that 28 years later, the data remains the same. So I'll stop here and I'm happy to answer questions or have a discussion.
Stan, thank you very much. I remember way back when my wife called me into the kitchen one morning because she had seen something on CNN, and I watched it, and the CNN news reporter said that there is a 50% increased risk of prostate cancer. And well, yes, 3% is 50% more than 2%, or 2% is 100% more than 1%. But boy, that 50% really stuck with the viewing public, and the phone started ringing that morning.
That's true. And it's funny because it's all about how you present something. And I actually went over this data with one of the urologists who is a really fine statistician. That's what he said. When you go from 1 to 1.5, there's a 50% increase. But if you look at the numbers and you have to take into account all the biases and every, study after study after study, 1.1, 1.2, 1.0, 1.1. I mean, I think we can safely put this to rest at this point. 1.1 is a 10% higher risk. So even that sounds bad.
Right.
It's really not.
Right. But the people heard 50%.
Yep.
And they said,
Absolutely.
oh, I have a 50% risk of developing prostate cancer.
Right.
Or it's 50 times higher.
There's a question from Dennis Jamonges. He asks, can you elaborate on how reduced prostatic secretion increases exposure to carcinogens?
I think there is no explanation there. I think these are all theoretical risks. And I think that there's a lot of research being done on prostate cancer, which I'm not really familiar in detail, but I'm not even sure how a decreased amount of fluid that is sitting within the ejaculatory duct is gonna, unless there's a local effect as it travels through the prostate, and certainly it's in the neighborhood. I always describe like ejaculation and erections as like, it's plumbing and electric. It's in the same neighborhood, but it's not really connected. Same thing with this. It's in the neighborhood, but it's not really connected. So I think that we've never really come up with a mechanism that made sense. And when I found this animal model paper, I found it kind of interesting that you actually could take a marker and see that there's an increase, whether that is cause and effect or whether that's going to make a difference in the long run. In humans, we don't know, but I thought at least the concept was somewhat interesting.
Let's put up chats. Any other way to post questions? Well, Stan, that was super. I was hitting print screen and copying your slides to a Word file, so just so that I'll have them when patients raise the question again.
Well, thanks. I hope that
They were super.
We can put this to rest once and for all.
Stan, I was wondering because, so when people are asking about the connection between, vasectomy and cancer, is it fair to say there really isn't a significant one that's worth, like we should just put it to rest? It's a non-issue, and because it's an excuse that a lot of people do use.
Yeah, I mean, I think that there's paper after paper. The original question that came up was with testicular cancer, even before prostate cancer. And there was, again, probably one poorly done paper, and then subsequent papers showed no relationship. Similarly, there was a question about coronary artery disease, and there was animal model and chimpanzees looking at this, and people were concerned about that, and then that was dismissed. I think that, when you talk about a procedure that's done in huge volumes and you have things that are true, you have to decide is it true, unrelated, true, related. Giovannucci also put a paper out looking at dehydration and bladder cancer that followed 2 or 3 years later. And again, there wasn't necessarily a kind of a mechanism of action. So I think we can clearly say at this point that that this doesn't need to be discussed any further.
I was curious if from the doctors themselves and anybody in the audience, if this is something that they hear all over the world. Is it something just, is it in the US or Canada? Is it something pretty universal? Are people seeing this example? Is it calmed down? How does it affect your practice? I'm curious for input from people. Feel free to raise your hand. I think you can be unmuted easily. So if you have a question, just let us, please let know.
Jonathan, I'll say something there. We don't certainly run into specific relationships of prostate cancer to vasectomy, but and the question has been pretty much put to rest, I think. But I did like Doug's idea that with all the work that Stanton has done on this topic, if your slides or just your references were available to all the doctors referring to, it may be very helpful in answering some of those questions that do come up sometimes from patients. And Doug's done a great job of accumulating a lot of his resources for us to refer to. So if I don't know if you'd be comfortable putting those up for people to download.
Yeah,
Yeah, my slides were sent to Deirdre, so I think they're available and you're welcome to use them to post.
Thank you.
Stan, it's well known that sometimes we as vasectomists we are the first doctors a 40 or 45-year-old man has seen maybe since he was in the military or in high school and he got his hernia exam. And the question will come up. I should be more up to date on this, I guess, but when should men have their prostates checked, even if they're not concerned about a relationship between that? What's the current thinking? Do you get your first digital rectal exam and do you get a PSA at the age of 50? Or just another question that comes up with regard to monitoring prostate?
Well, Doug, that's a really good question. And this is Movember, Men's Health Month. That's why we do a lot of this vasectomy stuff. And we do a lot of kind of patient education. And the answer is it's very controversial. It depends on who you speak to. If you speak to primary care doctors, as they read the literature, there's really no role for screening. The AUA guidelines recommend screening men between the ages of 55 and 70 for prostate cancer. And above that, it becomes kind of a personal decision. There are two groups that we screen a little bit more carefully. One is the African-American population because they have a higher incidence of prostate cancer and more advanced disease. And number two, family members who have had prostate cancer, and specifically first-degree relatives. So brother, father, not uncle, not cousin, whatever. It has to be a first-degree relative. As we move forward with other things like genetic testing, for instance, and even that is controversial, the BRCA genes seem to put people at a higher risk for prostate cancer. So like BRCA2 specifically, even a little higher than BRCA1, but most patients are not undergoing these genetic tests to give them an understanding of their risk stratification. But if this came up recently, I had a 30-year-old who came in whose mother had breast cancer, and he got this series of genetic tests and had a BRCA2 gene. And he said, well, when should I be scanned? And I reached out to my prostate cancer colleagues, and they said, yeah, there's a slightly higher risk, and they recommended doing it at age 40 as opposed to 50, 55.
Okay. So you would still, if you're a screening advocate, most of the screening advocates would recommend a digital rectal exam and maybe a PSA as a baseline at the age of 50?
Yeah, more actually the PSA. And well, what we've learned over the years is that PSA is a good test, but not a great test. The other thing that we've learned over time is that prostate cancer used to be thought of, it's like if you're pregnant or you're not, okay? All prostate cancer was the same. And now we know that there's prostate cancer is kind of graded on a Gleason grade and a Gleason score, essentially a Gleason grade of 6 to 10 score. Those with 6s are usually followed with an active surveillance protocol. Those with 8s or 9s are going to clearly need treatment, and they usually have advanced disease. And the 7s are the ones that are the borderline. You know, the small volume 7s, they may undergo active surveillance, especially if they're in their 70s, things like that. But others that are at Gleason 7 with moderate disease, et cetera, or those that aren't comfortable living with that risk, will go on to some kind of treatment. So it is a controversial area in the area of men's health.
Yeah, we've got a question for first degree relative. Should we start screening 10 years prior to age at diagnosis?
Well, we usually recommend screening at 40 for African Americans and for a person who has a first degree relative with a family history of prostate cancer.
Historically, wasn't there a time even when there was some interest in screening a little earlier if you've had a vasectomy? I'm sure that's long gone, but wasn't that a suggestion at one time?
Well, when this first came out, I think when we were concerned that there was a relationship, you know, everyone was kind of on the bandwagon to say, well, just, you know, screen them a little bit earlier. And I think that there's no compelling data to suggest that having a vasectomy puts you at a higher risk of having any type of sexual dysfunction.
You had mentioned the question of race in terms of the, you know, testing. I think you had said, if I understood, but one of the person was asking is does race get taken into consideration when, you know, calculating for impact, you know, relationship between vasectomy and prostate cancer? Has that been part of the factor?
I've not seen a paper specifically looking at race and confounding with vasectomy and race together. Maybe Michelle is familiar with some data on that, but I am not familiar with any data with respect to that. There's a question here that reads, did I read somewhere that if you have a PSA of less than 1 at 50, developing prostate cancer in the future is incredibly small? Yes, that's correct. You know, people who have PSAs of less than 1 at 50 or 60, we know that that particular subgroup has a very much lower risk of developing, you know, lifetime prostate cancer. That's, you know, that would be considered clinically significant disease.
Excellent. Well, I'm sure we could go on talking. I think we're doing pretty good for time, just a little bit behind, but doing well. Any last question, any last comment, Stan, you'd like to make?
No, I think thanks to everyone here. I think you do a great job promoting the concept of vasectomy around the world. And I appreciate, you know, what this listserv does for our patients.
Yeah, it's awesome. No, we're really happy to have, we don't know yet, but we did have over 100 people, which is really nice to see go into triple digits, and just, you know, the diversity of people around. And like you said, if there are more questions, put the questions down, send them in. We'll put together a list, and maybe Stan, if you don't mind, if you
You're happy to answer them. Absolutely.
answer questions. So, and for those of you who are not on the Google, that vasectomy group, that listserv that Stan is mentioning, get on it, because you can ask any question there and you'll get lots of answers and lots of opinions. So it's a very strong group that helps form, you know, collective knowledge, which is so important. So thank you so much, Stan, for this. Really appreciate it. And
My
we're
pleasure.
going to continue on. And the next thing we wanted to do is we do these little surveys, short little surveys, and they just take a few seconds to answer. But if people could take that, I think Gati is going to share just I think 1 or 2 questions, and please answer them, just so it gives us kind of running data and helps us be on top of, you know, just get more information, helps us do a better job. So Gati, would you post the survey questions now? And if you If you're not able to do it, let me know, please.
Yes, let me 1 second, please.
Okay, so we'll just take a few more moments. Yeah. We'll we have a long schedule, but we're pretty solid so far for time. We may not, I built in a little bit of a break, but we really don't need a break. It's a beautiful Saturday, and some of you it's already evening or probably early in the morning, in fact, depending on where the time zone is. That may be the biggest challenge we have, is just making an event that accommodates for all of the time zones, which is why we record the event and share it later on and send it around to people. All right. How are we doing on that? Kati, are we ready to put up that?
It's up.
It's up. Okay, so now you guys should have the chat. I don't see it on mine, but does everybody have that survey question? I don't see it, Deidre. Do you see it?
Yes, I do.
I've got it here, John.
All right. Do you want to share that on the screen, or is it just everybody getting it sent to their computer?
Can Stan's screen be removed by any chance?
Yeah. Stan, you can stop sharing your screen at this point.
If it doesn't share the screen, it would help.
Okay.
Yeah.